Bethesda, Washington. And then his advanced cardiac imaging fellowship. In fact, he was an inaugural fellow for an NHLBI multimodality fellowship program, which was held in conjunction with his appointment as a fellow also at Bethesda, Washington. Dr. Choi is known for his work in atherosclerosis imaging, and he's also known for his work in coronary CT imaging. He has been a prolific mentor to several trainees, and I found that he loves diversity. So over 50%, half of them have been female trainees. So it's actually mentioned in his CV. So he is in multiple committees in national societies. He's on multiple editorial boards of several journals, esteemed journals. And I browsed through his awards. No doubt he has been prolific, and he's been multiple Young Investigator Awards and academic awards. But what I found was 2 awards which were worth mentioning. In 2012, he was the Rising Star of ACC. And then I was surprised, in 2001, he was a Barry Manilow Endowed Prize in Music. So obviously, there is some musical touch, which I do not know about. I came to know. And in 2021, he also had a Distinguished Service Award from ACC of Maryland chapter. He has over 80 publications, several grants and funding, which are in cardiac imaging, plaque characterization, and lipid lowering. And today we are going to be excited to see a journey in an area of real attention that is required, particularly here and elsewhere in the country, on how coronary plaque characterization can lead to a journey towards better understanding of both coronary physiology, and then understanding how we can prevent the consequences of a disease which we, to be honest, have not had a much handle in a very long time, and probably just starting to understand the physiology and the biology much better. So, Andrew.
Well, hi, good afternoon, everybody. I think sometimes when you hear your CV being presented, you're a little bit embarrassed because they ask, well, Dr. Choi, can you walk on water? And the answer is certainly no. And I'm also a little bit embarrassed because I think, a lot of the work that we do is really underlined by the relationships that we have. And what I've just been able to spend a little bit of time with your chair here and with some of the colleagues is really just the warmth of relationships. And I think that really underlies what we're doing in cardiovascular medicine, what we're doing together as a field, and a lot of the collaborations that we've been able to accomplish, through artificial intelligence and that are happening here in this center of innovation are really underlined by kind of a mutual passion. And I hope that we can share that together, through this talk. And so let me advance the slides. And I also recognize that through COVID, having in-person talks is something that's also novel. And at our institution in Washington, we've had a lot of these hybrid talks. We've had these virtual talks. And so I think it's great to be able to meet with you. And it was important for me to be able to come up and see you in person today, because I think it'll let us have some nice engagement and encourage just a discussion with our group today. And so we'll talk about CT atherosclerosis imaging and AI as a vision for a brave new world. And if you understand literature, Al Huxley wrote this book, Brave New World, talking about, dystopian society, where may we, where would society be with these advancements in technology? And there's a certain irony in that book, in that literature. And what I hope to be able to help show you is how this technology may not lead to a dystopian world, but hopefully a better world for us, where we can really prevent heart disease. These are my disclosures, and we'll point them out as we go along. A couple of simple objectives. First is to really be able to understand the principles of AI with emerging applications in cardiac imaging. Second is to demonstrate the evidence for AI and the CT diagnostic accuracy to improve reproducibility of stenosis. We want to survey what are the opportunities for us to enhance and rapidly allow for AI-guided atherosclerosis quantification, and what are some of the frontiers that we have available to us now through prevention and through AI. And so if you've been following in the lay just literature and in the news, again, you've got a lot of expertise here. And so I'm preaching to the choir. ChatGPT has been what's been really in the news for the last couple of months. Not so great at solving complex cardiology cases, but it performs well in cardiovascular trivia. And I think we'll see some interesting data coming in the imaging space as well with the role of ChatGPT. But a lot of the headlines that you're reading, does it show promise in assisting physicians? Will it beat doctors in compassion and quality of advice? I was very interested in this. And so we were talking, can it beat the Turing test? Can it beat what we have as clinicians to be able to offer in being able to, give advice to patients and being able to speak to empathy, speak to the relationships that we're able to form with our patients? And that is kind of where the frontier of AI is at. And so maybe, AI can beat the burnt out clinicians, the burnt out physicians that have come out of this COVID pandemic. At our institution, our trainees have just voted to unionize, and I think it's a response to what's happened through COVID. And I think maybe this is one of the directions that will go. And in the Washington Post this month, the next level of AI is approaching. Our democracy isn't ready yet, and so maybe this has broader societal implications. Now, here at Rutgers and Robert Wood Johnson, you are a national leader in artificial intelligence and cardiac imaging. Echocardiographic imaging and microscopic changes in how you're using radiomics to look at texture mapping for risk prediction. New pathways to discovery with the private sector, and a lot of the discussions today are the collaborations that are ongoing because a lot of this work is public and private partnerships. And also, Dr. Sengupta and others that have been really recruited here, and how you're building trust in AI and what are the opportunities and challenges for cardiac imaging. Dr. Sengupta being the national leader in this space and really helping to set the guidelines and standards like the PRIME checklist that I'll show you at the end. To bring this from AI imaging to CT imaging, the field of CT imaging now has really evolved over the last 2 decades. And so on the left of this figure shows you in 2006, the emergence of 64 detector row CT, which is still a base standard for atherosclerosis CT imaging, really coincided with some of the major advancements in the field. And so if you think of the COURAGE trial, thinking of stable patients undergoing treatment for stable coronary disease, that medical therapy is just as good as intervention when it comes to heart outcomes, although there are symptomatic benefits with interventions. As well as new developments around education and competency in CT. And as the field has evolved, the FAME trials for FFR, the guidelines have evolved as well, leading up to the 2021 ACC/AHA chest pain guideline that now puts CT at a class 1 indication alongside our functional modalities. The future, now that we have this establishment of the guidelines, are around advanced imaging modalities as well as machine learning and artificial intelligence. And so if we think about CT as a modality, it's not only about image enhancement, but also about image reconstruction, around image acquisition, risk prediction on not only an individual level, but on a population level, and how stenosis evaluation, coronary flow assessment, and how these tools really look to give the gift of time for clinicians, but also advanced new practice. And a lot of the why, why do we need these new tools? We have a guideline now, and the guideline writers, and I was one of the reviewers for this ACCHA chest pain guideline, and this is the opportunity to give big congratulations and kudos to Martha Gulati, the chair, Ron Blankstein, Leslie Shaw, and many others that had contributed this over 4 years of blood, sweat, and tears. And really is a revolutionary new paradigm. And how do we implement this now in clinical practice? Three major messages out of this guideline for around CT imaging. One, in intermediate risk acute chest pain, CT now achieving a class 1A recommendation, that there are multiple randomized controlled trials showing evidence of benefit. That is class 1A for intermediate to high risk stable chest pain. And that I think importantly, the paradigm of non-obstructive atherosclerosis being important, and this really being the first time in an ACCHA level guideline articulating that as a key aspect of chest pain and CAD imaging. To bring this into a more practical level, again, why are we thinking about this? Why do we think about artificial intelligence? So you have in the left, Bill Clinton. In the middle, you guys know who the middle figure is? Tim Russert, all right? Tim Russert was taking care of a cardiologist in Washington on K Street. And on the right is Rosie O'Donnell. And so Bill Clinton, former US president, had a heart attack at the age of 58 after having a normal stress test. Tim Russert died also at age 58, had a normal stress test, but had a heart attack in VF arrest, and Rosie O'Donnell having a heart attack at the age of 50. And so all young individuals suffering from heart disease. The paradigm of how we're thinking about CAD has evolved in the last 30 years. And so 30 years ago, we thought about how do we treat the end stage of disease? Coronary stenosis is a focus of treatment and disease detection, because what we had also available was perfusion imaging and stress imaging. And as we have evolved, now we're thinking about individual level patients. We're thinking about not only that end stage of disease, but subclinical disease and early atherosclerotic burden. And how do we really detect that, and how do we prevent that? From the American Heart Association, 20 to 40% of heart attacks are occurring in undiagnosed patients. And we've been focused on this tip of the pyramid. And this is an editorial in JACC with Aaron Mikos, Johns Hopkins, right? So we've been focusing on treating disease, treating heart attacks, treating ACS, but it's only the tip of the pyramid. And how do we better address those patients that are at the mid and base of this pyramid, and really thinking about prevention and how we incorporate that are not only our risk factors, which tell us part of the picture, but how we incorporate new methods of CAD imaging, new methods of atherosclerosis evaluation, new methods of flow quantification, as well as integration of polygenic risk scoring, microRNA, inflammatory biomarkers, and to really have this as a new model of prevention. You guys seen this picture before, right? So this is the peak of Mount Everest, right? And this is when there's a small window of time each year that one can go in to try to summit the peak. And this is what can happen, is right, there's a whole kind of a rush to get up to the top, and everybody gets stuck in the middle. And I think this is where the field is at right now in cardiac imaging and CT imaging. And so the evidence base is tremendous. It's Mount Everest. It's the best in the world. But access is limited in many places, and there are a lot of challenges. Cardiology, radiology collaborations may be one of the challenges. The training duration is long. For us to be able to meet demand right now, it's estimated that there are about 300,000 patients that are undergoing CT each year, but there are 20 million patients that have established coronary disease, and there are 100 million patients that are maybe at risk of having coronary disease. And it's going to take about 10 years for us to train an expert. So we don't have the capability, I think, to be able to train all the people that we need to be able to offer these approaches to people, and the need to rapidly expand into the front line and also primary care clinic settings. And so perhaps we can fill this gap not only through expert readers, but also through artificial intelligence. And so this is a myth, right? AI is going to replace all of us without enhancing cardiovascular care. And there's a fear of AI. Well, as you know here extremely well, that there is this tremendous growth in healthcare data. It was estimated at Berkeley that it was 153 exabytes a year, well above all of the words that have been ever spoken in humankind. But that has really grown even to 2,300 exabytes. And so the amount of information that we have available to us is overloading us. How do we solve big problems? And, again, here, I think being really one of the leaders in the country and thinking about this, but around novel drug therapy, disease stratification, integration of multi-omic data, and physician efficiency, how we're giving the gift of time, or, a question here, optimize resource allocation, or how you might prevent heart failure readmissions. And on the right here is how some groups are using genomics to be able to predict statin response and non-response, and how you might be able to take preventive therapies. We'll talk about at the end here beyond not just statin, but we've got multiple drugs that are available: ezetimibe, bempedoic acid, PCSK9 inhibition, siRNA inhibition, and new drug therapies that are coming. And so how do we really allocate that to the people that need it and in the right environments? Now, AI, as you know, it's any technique that enables computers to mimic human intelligence using logic, decision trees, and machine learning. And so how do we use computers to be able to mimic human intelligence? How do we use statistical techniques like deep learning and decision trees to be able to accomplish that? And how do we train machines to be able to perform tasks using CNNs, convolutional neural networks, or recurrent neural networks to be able to accomplish these tasks? A part of everyday life, as you know well, whether it's your Alexa at home, your smartphone with facial recognition, or self-driving cars, are all already part of society, slower to integrate into medical practice, and we have to be the ones that validate that. And so, again, you know this, I've seen this already. This is simple object recognition. And so how you train a machine to be able to look at different things within this video, whether it's a car, a person, a bus. And this principle is what makes it very feasible around cardiac imaging space. Now, we do have to manage our expectations and caveats. And this is a slide from Ed Nickel. And thinking about, what are the things that AI are good at, but also what are the weaknesses? What are the biases that exist? And so if your data set doesn't fit what you're actually trying to do in the real world, then you may miss things. What's the methodological rigor that's taking place? Is there internal, external validation? Is there a validation cohort that's showing you what you're doing? And does it reflect what you want to actually try to study? There are commercial interests. You have to be aware of fool's gold. There is a lot of private investment and private equity investment that's going into these technologies. And they may have different goals than what you or I do. You or I are centered on the patient and trying to deliver the best outcome for that patient. But company may have something else in mind. And then we have to approach this technology with the same kind of scrutiny that we do any kind of data, any kind of evidence that in cardiology. Cardiology is built on a foundation of randomized controlled trials, and we don't have that yet for these AI technologies. And it's up to the field to be able to prove that. We need to understand what's in the black box, and we don't want to solve problems that we don't have. And so, the example is, pleural fusion on a chest X-ray. Well, it's a nice problem to try to solve, but is that something that we really need to try to solve? Because it's simple to do. It may take you or I just a couple of seconds, or a radiologist to be able a couple of seconds to read a chest X-ray. So we don't need the AI for that. We want the AI to solve things that we can't do ourselves easily. This is an example of bias, and so whether you underfit or overfit the model. And so on the left, what do you have here? Right, it's President Obama. The model, and this is like a famous Google example, right? The model didn't account for the fact that President Obama was a Black man. And so when it reconstructed it, it got his features right, but it reconstructed him out as a white man instead. And so, and we can kind of think about this in any of the AI problems that we want to put together. And so, another way to think about this is how you might put together this bicycle where you have component pieces and you have to put each of the individual pieces together and train your AI to be able to build that model. And it's the same thing here. And so you may ask your AI a simple question, right? Can you differentiate between calcium or non-calcium? And using the series of convolutional networks across a 1000 by 1024 matrix, and then taking it down on within that matrix, within a voxel, and within a voxel into a pixel, being able to train that model, what's being seen, so that you can answer a simple question of calcium or not calcium present, and then to build it back up until you answer a question of not only that individual pixel level, but being able to look at what's happening in the image for structure segmentation, for coronary segmentation, for plaque characterization, and then plaque quantification. And so now to get into kind of where I think the field is at, we've talked about, what is it, why do we need it, and what is, why do we need the AI and in CAD imaging, and what is it? So my first take-home point for you, AI can now allow for accurate and direct image assessment of CAD. What does that mean? So the field was initially interested in risk prediction. How do you take large databases, and this was from the confirmed registry of 25,000 patients, images that were already read, put into a database, and you're using logistic regression to be able to predict, whether a patient would have an MI or not. And the idea is that this is what you or I do when we're at the bedside, is integrate all the experiences that we have to be able to tell a patient, are you going to have a heart attack or not? And let me help you do that treatment. And so, Subi Alaraf, who's at Arkansas now, used XGBoost using 25 risk factors and calcium scoring, and showed that, well, all right, a machine learning model could do better for risk prediction, but the images were already interpreted. Where we then sought to ask is, can we teach the machine to do what we do already pretty well, or maybe even do better than that? This is from the PROMISE trial. So if you remember the PROMISE trial, 10,000 patients, multi-center trial, randomized to anatomic imaging versus stress testing imaging. What Michael Liu did was to evaluate how did the core lab do to the readers that at the time, if you think back to 2009 when PROMISE was starting, most of those readers were level 2 readers. And as the field was nascent, the readers were also building their experience. What they found is that the core lab interpreted 41% less patients as having significant CAD, meaning that 40% of the time, the scans are being overcalled, right? That we think that the real world readers were overcalling disease because maybe they didn't have the requisite experience. And so more experienced readers are more accurate than less experienced readers. And so that led us to this first study, and this was clinical validation of, and we think about what are the right standards around imaging? How do you prove that a new technology is as good as what you have or better? Well, we set up a paradigm of this, of how do we establish CT against expert readers? Then what are the other gold standards in the field? It's invasive angiography. It's invasive fractional flow reserve. It's an intravascular ultrasound and near infrared spectroscopy. And so after a developmental process of seeing how can you create a model of segmentation, how do you create a model of coronary stenosis evaluation, we then tested it in a multi-center trial against expert readers. And this was to see how could AI guidance of CT coronary imaging compared to expert readers for stenosis assessment. And the basic idea of how this works, so that we can get into the idea of the black box, is what's shown here. And so the way that the AI, it takes images that are uploaded to a cloud-based server, automatically goes through the images to pick what is the best series for image quality among those set of images, and then does automated coronary segmentation to pick out what's coronary, what's not coronary, automatically labels each of the aspects of the coronary tree, so whether it's LAD, circumflex, or right coronary artery, then picks out individual segments, proximate and distal LAD, and then to be able to pick out, all right, what's the level of stenosis in each of those segments? What's the type of plaque that's present in each of those segments? And it uses a series of convolutional neural networks, or UNet and VCG network, to be able to give the output. Just so that you know about the validation, from over 1 million images from 23,000 vessels and 3,600 patients, the lumen vessel wall algorithms were from 1.4 million images from 8,500 vessels and 3,600 patients. And to make this now palatable to you and I as clinicians, presented as a graphical output. And again, note, I do have a very small COI here. But what this does is it tells us through this graphical interface, right, is there stenosis that's present in any of the coronary vessels? What's the amount of atherosclerotic plaque that's present on a level of millimeters cubed? And are there high-risk plaque features? When you think about this process and right, the question of, is this a problem that we need solving? Is this something that we can do well? The process of doing coronary segmentation using semi-quantitative methods that belie a lot of the papers that are in JACC imaging takes hours to do, maybe even 6 to 8 hours to be able to do, and is not available in clinical practice. And the goal with this is to be able to bring this to a clinician. The average analysis time is about 10 minutes. The FDA mandates that there is a human level review for any kind of AI product. And so I'm told it's about 10 to 25 minutes to be able to do this. What we found was that the accuracy of AI about 95 to 99% accurate on a per patient and on a per vessel basis when you compare it to level 3 expert consensus. We sought to look against a QCA standard, so CATH and FFR. And so this is a multi-center study of the Credence trial, an NHLBI funded study. And again, big kudos to really the Credence authors, led by Jim Min and many others that had put this together, Leslie Shaw. And what we sought to do is to see how does AI QCT compare against an invasive angiography standard as well as invasive FFR. We found is that the AUCs on a per patient basis for 50% stenosis and 70% stenosis, the established standards of the field, were accurate and were similar to QCA and also similar against an invasive FFR standard. Now, interestingly, in the cases of discordance, there was about a 10% atheroma volume. When the AI QCT, so the AICT, didn't agree with invasive FFR, there was still significant plaque burden in many of those cases. Ed Nickel, a great colleague, wrote the editorial for this in JACC Imaging. And he made a comment in there that says that, does a study make a slight mockery? So my apologies to the interventional colleagues in here of invasive angiography or QCA as a gold standard, because maybe it doesn't pick up on plaque in the same way that this does, and that some of our gold standards are imperfect, and we do rely on kind of a multi-parametric approach to thinking about this. We found that AICT was accurate over stress perfusion as well against a QCA and FFR standard, predominantly SPECT imaging here as well. And so just to summarize this work, the last really 5 years now, AI-QCT, highly accurate versus level 3 consensus, and against QC and FFR, more accurate than stress perfusion, allows for a wide range of atherosclerosis evaluation, and is rapidly done. Second take-home point is the evaluation of quantitative atherosclerosis over 1 billion pixels a day to apply in clinical practice. And so let me take this from some of the theoretical things in the trials to a patient. And so this is a patient from our institution at GW, a 50-year-old man who had presented with shortness of breath, hyperlipidemia, positive family history of CED, and a smoker. And so on the left is a CT image based on the level 3 consensus read. What do you see? Just so that we're in person. So what do you see on the left here in the coronaries? Yep. So there's some spotty calcification that's here. And no obstructive CAD, right? So what you're seeing is a pretty bland coronary by the naked eye, is that there's kind of minimal stenosis here. And so on the screen projection, there's a little bit of plaque that's present, a little bit of calcified plaque, but really unremarkable. Well, if you look in the middle image and you apply AI to it and do plaque quantification, and the standards and the thresholds are based on established standards in the field, the plaque volume here is quite high, 550 millimeters cubed. And so even with this patient with kind of minimal stenosis, there is a high plaque volume that's present, and there's low density plaque that we've seen in other studies, and I'll show in a minute, that are at risk for intermediate or long-term risk of plaque rupture. And I'll talk about what this, what these thresholds means in a minute. So what do we do about this patient? And what are the implications? Well, why are we here, right? Why did you go into cardiology? Why did I go into cardiology? It's to prevent heart attacks and to treat heart disease. You're known for the last several decades from multiple studies, and more recently from CT-based trials called ICONIC, the PROMISE trials we talked about in the Western Denmark registry. 2/3 of cardiac events are happening in patients without obstructive stenosis. And these are the ones that we have the hardest time in identifying. Here's the most recent, really interesting data. So on the left is the Miami Heart trial. And what Miami Heart was a very diverse cohort, 2,500 patients, much like that here in northern New Jersey. 50% were Hispano and Latino, 40% were non-Hispanic white. The mean age was 53 years old and 50% were women. And among this group, there were 50% of patients. This is, again, population, asymptomatic patients. Half of patients had demonstrable plaque. On the right from Sweden, this is 20,000 patients from Scapus and published in Circulation. 42% of patients had demonstrable atherosclerosis. About 5 to 7% of the time, they had severe CAD, and 16% of the patients had a calcium score of 0 in the Miami Heart trial. So are we missing a lot of patients that are walking, I don't know, we can think about, half the people in this room, maybe have CAD and we don't realize it or we don't know it because we haven't had the best tools to be able to detect it, especially at younger ages. We have, again, the underlying evidence for the ACC chest pain guidelines or multiple randomized trials. And so the Scott Heart trial, randomized stable chest pain patients to standard of care stress testing versus standard of care plus CTA. So 40% relative risk reduction in MI and coronary death over 5 years. The PROMISE diabetes, a sub-study looking at the diabetic patients only, significant reduction in CV death and MI in diabetic patients. And on the right, published this past year, the discharge trial, Mark Dewey and colleagues in Europe, about 30 centers, just randomizing patients that you would be sending to the cath lab with chest pain, but randomizing them to CT instead. And it's a follow-up on Jim Min's study from earlier, but just larger, but published in the New England Journal. CT reduced major complications, fewer revascularizations, similar MACE versus invasive cath, and probably because you're doing just not doing the invasive procedure. We learned from the Scott Heart trial from Michelle Williams and post hoc analysis that plaque burden best predicts events, and it's independent of risk score, coronary artery calcium scoring, and stenosis. But to be able to do the plaque burden here in their methodology was a research tool and wasn't something available in clinical practice. And so the next era of imaging will incorporate this this information from quantitative plaque to facilitate individual patient management and improve outcomes. When we think about plaque on a very nuanced basis, I think one way to think about it is it calcified, right? Is it calcified plaque? Is it non-calcified plaque? And what we've learned is that the calcified plaque is actually the more stable plaque. And when you're looking at a calcium score, maybe a calcium score is more of a plaque biomarker rather than the plaque that's prone to rupture. And what this figure is showing you is that what Alex van Roosendaal in the Netherlands very cleverly showed through JAMA cardiology, and they coined it 1K plaque, is that the calcified dense plaque over 1,000 Hounsfield units, which they called 1K plaque, was lower risk and stable and not prone to rupture. Whereas Jagat Narula, Motoyoba 15 years ago with the early papers looking at this, is that those patients that have a necrotic core, Hounsfield unit less than 30, are the ones that are higher risk or the plaques that are prone to rupture. And this is the data from ICONIC, which looked at, it was a case control study, but looking at patients from the 25,000 patient confirmed registry and then going back and seeing who are the ones that had MI, and that the necrotic core patients are the ones that were more likely to have a heart attack, whereas having the calcified plaque was more protective. And so this spectrum of atherosclerotic risk. When we think about CAD, right, our paradigm, and as a clinician, I think about, sometimes it's simple, and I think about it this way as well. does my patient have, 70% stenosis or not? But CT allows us to really identify a really broad range of atherosclerosis, not only stenosis, but plaque burden, location, length, concentricity, eccentricity, direction, diffuseness, composition, necrotic core, remodeling, and morphology. So, there's a lot of stuff on this slide, right? This is, if you're a fellow, right, make your slides simpler. Is it realistic for a human to be able to evaluate all of this stuff on a day-to-day basis? Right? If you're in the if you're in the echo lab, right? Let me this is maybe we'll take this just to kind of day-to-day. So for your ejection fractions, right? Do you guys do a visual estimation, or do you do 3D quantitation, or what? How do you guys do it? You do biplane, all right? Biplane imaging, right? That's fair, because it's simple to do, and you have reproducibility to do that. And part of the reason is you're busy, right? You have to get through 30 to 50 echoes a day, and so you're trying to find a methodology that works best. And so, right, the quantitative tools are nice to have, but they are more time consuming. And this is where the why, why does this matter? And if you're trying to do quantitative atherosclerosis, it is not realistic for a person or a human to be able to do this. And so, kind of going back to where we kind of started with this, the average imaging specialist, it's been estimated that if you're a reader, you may have to do over 1 billion pixels a day. One global healthcare data is now 2,300 exabytes. 1 exabyte is 1 billion gigabytes. And to record an exabyte video call would take you 237,000 years to be able to do that. 5 exabytes are all the words that have been ever spoken by humans. And so the amount of data that even on a scan you have to process is tremendous. Now, how do you apply this across a patient? There are other methods. This is from Michelle Williams again, multiple emerging methods to atherosclerosis quantification. And so I really want to make sure we point out there are multiple methods of varying levels of validation. And again, plaque quantification is one of the outputs here. And so what we found through our study is, first, AI could identify a wide range of atherosclerosis. And then we've been now trying to figure out, what does this mean? We found that there is good accuracy against the invasive standards, so near field infrared spectroscopy and IVUS, and this is data from Japan, where they do a ton of invasive ultrasound and have been a really wonderful collaborator. And at SECT last year, showing that quantitative plaque burden, and through a novel plaque staging system that's been proposed, that may be mild 0 to 250, moderate 250 to 750 millimeters cubed, and more than 750 millimeters cubed, will help us prognosticate. And we have upcoming, hopefully we'll see it out, it's 10-year outcomes data with, we have my research fellow from the Netherlands has been looking at this, showing that AI-guided plaque quantification being superior to clinical methods, superior to clinical calcium scoring, and even better than what's set up in CAD-RADS 2.0 with a segment involvement score. And so I think this, hopefully, it's under review right now at one of the major journals. We'll see this in publication, really help to show you and show the field where this field is going. Dominique Day and colleagues in Cedars-Sinai doing really outstanding work in multiple domains by using deep learning CTA, also showing important accuracy versus intravascular ultrasound, and finding very similar plaque volume thresholds. Here they had 240 millimeters cubed being predictive of events, both for that and also for stenosis. And that was in Lancet. Radiomics, I know the work here on radiomics and echocardiography is an area of interest. And there's also been radiomics from Mrs. Palmarovich and colleagues looking at radiomics phenotyping, really trying to break that image down into really the radiomic level to be able to segment out the plaque and to be able to predict cardiovascular events. So now, why is this again? So a lot of technical aspects, you may not be imagers. So, how does this apply to me as a clinician? How do we use AI to advance new frontiers in precise, individualized risk prediction and prevention? Let me give you another case. This is my patient, 55-year-old man with hyperlipidemia, presenting with acute chest pain, with walking, active lifestyle, jogs, lifts weights. So, probably very much like a patient that you'd be seeing here in Northern New Jersey. Had actually very well-controlled cholesterol, but had a stress echocardiogram, that was normal 1 year prior. And so this is what the CT had shown. And so on the left here, moderate grade LAD stenosis, so in the red, with a non-calcified plaque that's present, and the 3D here is showing that as well. On the right, severe RCA stenosis. This RCA was intervened on because it was thought to be the cause of his symptoms, but what to do about this moderate LAD stenosis? And this is right at the time the ischemia trial came out too. So it was really kind of a multiple layered question of what to do about it. And I think I don't know how many folks would intervene on a moderate stenosis or do both. Right. I guess your group is is very you do FFR. All right, that's fair. Right, do an FFR on it and decide whether to intervene on. Probably the answer 15 years ago is that or 20 years ago is intervene on it, right? Because that was what the field said, is that anything over 50%, you stent it, and that was dogma. Well, we decided to leave it alone, and it's also a reminder here of the CT. Normal stress test does not mean the absence of coronary disease, as was the case in this patient. So he got his CT scan. What he did was he changed his lifestyle because of what he had seen. So vegan lifestyle. He started exercising more rigorously, 45 minutes a day. He initiated lipid-lowering therapy. And I want to come back to this idea because this is where the plaque is going to be very so powerful for us. Plaque has a sex-specific signature in women, and how do we really personalize things for patients? And if we can identify quantitative plaque or low attenuation plaque, and that may be how we differentiate between men and women. The EVAPORATE trial. This is a trial of much discussion with my good friend and colleague Matt Budoff and others. And so the use of icosapent ethyl for these patients that have high triglycerides and the progression of atherosclerosis. And so what they found was that if you gave icosapent ethyl, you could have a significant reduction in quantified low attenuation plaque volume on CT, and it provided an important linkage of cardiovascular events to an imaging phenotype. Again, what they used was semi-quantitative methods and METIS. It was a small number of patients because they didn't have the technology available to apply this on a more broad basis. But what EVAPORATE does is start to provide a scaffolding to helping patients and also studying new drugs. When you think of, again, the preventative drugs, what do we have available in our armamentarium around prevention? This is what I'm excited about these days. In the field of prevention over the next decade is this, right? How do we apply statins, icosapent ethyl, P69, lifestyle, colchicine, NOACs, and how do we really incorporate that with imaging? And so, really for the clinicians, this is the thing. This is a slide to really take away is where is this AI going to help us? Not only risk prediction here for major adverse cardiovascular events, but predicting those that are going to progress rapidly, predicting those patients that are going to respond. So how many of you have had a patient that was on statin but still broke through and had the heart attack, right? And why did that happen? Was it that, maybe it's that you think, and which I'm with this, maybe you were missing their LP(a) that was elevated, but just wasn't checked before. When Horizons come out, maybe we'll get a better treatment around LP(a). Sometimes I use LDL particle concentration just because I was trained in that 20 years ago. So there is some role for biomarkers here, but also direct phenotyping, I think, is how we can do better individualized prevention. Benefit from invasive catheterization, ischemia prediction. And on the right are how we can start to really look at plaque regression. Right. This is a kind of interesting question. How many, have you had a patient that asked, right, if I take my drug therapy, take my statin, is my plaque going to actually get better? Is it going to actually get better on the inside? And I have every patient that I see in my clinic is asking that question. Is it going to get better? And so, a lot of the new drugs that are coming down the pipeline are also asking that question. And we need to be able to study this in large trials. We need imaging, unless we're going to devote, money that we don't have, billions of dollars into just hard outcomes. We have to do these trials first to be able to predict what the response is, so that we can apply this more broadly. And I think AI guided CTA is going to be what wins out, but it's not the only method. MRI, OCT. Steve Nissen did Asteroid 20 years ago using intravascular ultrasound and rosuvastatin, right? IVUS is very hard to do. Patients don't like getting it because it's invasive and it's expensive to do. So, while it is the gold standard, it is hard to do it on a larger scale. Let's see some chat questions or CME. All right, so going back to this patient, he had AI-QCT applied. And we have this because we're developmental site for this, but we applied it to the patient. We told him what and why we were doing. With his LDL in the 50s, over 2 years of follow-up. So what are you seeing on the left versus the right, and what has happened to that plaque? Right, so if you look at the color, color coding kind of helps you with that in the stenosis. Right, so what you're seeing is that there was the demonstrable regression in the plaque, and also, what you're pointing out really smartly is that there's some plaque stabilization that's taken place. And so using AI-QCT now, we can put numbers on this. So 40% plaque regression in non-calcified plaque, and a reduction in stenosis from 68% to 31% stenosis. And because we've tested, we can be assured that these numbers are accurate. And so plaque stabilization, there's an increase in the calcified plaque, which is probably indicative of a statin treatment. And there's plaque regression of all the non-calcified plaque components that we quantified, about 40% non-calcified plaque regression. And so, I showed this to this patient, and he was overjoyed to hear that his, not only his lifestyle modifications, which are the foundation for everything we do in prevention, but also his drug therapy had this kind of effect. It really gave not only kind of important feedback to him, but also really proof of concept. And so now, let me stop there for a moment before I get to this last part. Any questions? Because that's this idea of, I think, prevention, incorporating atherosclerosis imaging, I think is really what's most exciting about the next 10 years in the future. And I want to talk about some novel technology in a minute.
How much is the average regression you're seeing frequently?
Yeah, so the question from Dr. Sengupta is, what's the amount of plaque regression that has been seen? And it's an open question right now. So one has to think about how are you controlling for the different types of ways that you might be able to demonstrate regression. So are you going to first study an LDL patient population and look at on treatment with changes in LDL? Are you going to look at LP little a and see what the changes in regression are? And then can you also model what type of treatment that's been on? Because some of the databases that have this can tell you whether they've been on treatment or not, but they may not be able to model it. I think in the patients where, so we've been asking these questions and working on some collaborations, we're also trying to figure out what's the right number to be able to predict this and show this. And so, maybe the meaningful endpoint is maybe at least 5 to 10% regression if you have LDL lowering or LPA little a lowering. And that's what some of the data has been showing us. The question has to be answered also through a randomized controlled trial. So, and some of this also goes back to image quality, to be able to answer the questions in interscan variability. Because if I say it's 10% regression, which is some of what we've been seeing in some of this preliminary data, well, you might tell me, maybe there's a 10% interscan variability that takes place from patient to patient. We have to adjust for that right now as well. So it's an open question that you're asking. Yep. 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 Yeah, so the question is, all right, let's take the RCA out of it and just say you had moderate LAD stenosis, and you had a patient coming in with chest pain, and you're trying to understand, all right, what's the right thing to do for this patient based on the evidence. Say you apply an FFR, so we'll pick one, either an invasive FFR or a CT FFR that tells you that the FFR value is negative, meaning that it's over 0.8, so it's a non-ischemic vessel. Right? And how do you tell that patient it's going to be okay? I think a couple of ways that I would answer that to you based on evidence. One is that, well, we do have the ischemia trial. And so the ischemia trial took 5,000 patients and randomized them after getting a CTA. They took out the 8% of patients with left main disease. And then if you had moderate to severe ischemia, had optimal medical therapy or invasive testing. And so this patient could fall, although he doesn't have ischemia, so he doesn't quite even meet that criteria, right? Because you've said the FFR-CT is negative. But if you kind of extrapolate that, you'd say, well, you do okay with medications based on that data. I think the kind of fundamental question is going to come back to their symptoms, right? So is this the cause of their symptoms or not? And I think then you have to have one, do you have an accurate means of testing for ischemia? I'm going to show you some of the recent CT-FFR data just published that adds a layer of, I think, challenge for this type of lesion where it's like 69%. So is a CT-FFR even accurate in that range? And that's where I'm at right now, and I'll show you why in just a minute. And so I think fundamentally it is based on symptomatic benefit, not mortality benefit, right? They're not going to live longer if you're out, but you might make them feel better. And then maybe you ask the question, we were talking about, microvasculature. Maybe that's where your PET imaging also fits into this paradigm. I don't know. What do you think? I don't know. Yeah. Yeah.
The reason we are able
Yeah, so advocacy issues underlie all of this, right? And this goes back to 20 years ago when CT came about and where CT was put into the cost center at CMS. It was put in a cost center that didn't quite make sense, and so the reimbursements have been too low. Other imaging modalities like PET have been much more, I think, successful in that realm. There is a level 3 code that now has been created around plaque quantification. Just as the one for flow, coronary flow is right now being debated as a level 1 code. My prediction is that the level 3 code will be moved up to a level 1 code before too long. And now the cost, now you have to think about cost. So cost of a general CTA, speaking as an academic, right, and being as neutral and fair to what the reality is possible. So, say $200, right, is what the reimbursement is for CMS for CTA, where the pricing is set for flow and for plaque quantification are each at $950, and they were set based on one another. Now, I think industry is taking a different kind of nuanced view of that. And I think the ones that will be successful will be the ones that are the most collaborative with their sites, and we'll leave it at that. But the question is not only a cost, it's not the upfront cost is what matters, it's the downstream value that you provide. And so will you be able to provide value to a healthcare system by reducing excess testing and to be able to target the testing in a way of which you have the most benefit? And so, maybe your health as a broad healthcare system, and Lee Health is one example. Rick Chazal, who's past president of ACC, is the one that's been kind of pioneering this or thinking about this. So in a large healthcare system, maybe if you're preventing heart attacks and, from an accountable care organization, you're presenting cost savings. And so government is happy and our patients are happy because we're helping them to live fuller lives. And by reducing the less invasive testing, then maybe we also have cost savings to the healthcare system that we can really kind of increase our preventative care. And so I think it's not a cost question, it's a value question. And, will this provide value? And, we'll see what happens. Yeah.
What is your message?
Yeah, so questions about coronary calcium scoring with or without hyperlipidemia. So I think it is an important role. So this is Roger Blumenthal, right? They got this into the blast prevention guideline. So for those patients that are at 7.5 to 20% ASCVD risk, do you use calcium scoring decision tool to de-risk or not, especially if you have a calcium score of 0? And so calcium scoring, I think, can be a high value proposition because it's an inexpensive test to be able to do. If you have a calcium score of 0, you can de-risk those patients. The challenge with calcium scoring is that 15% of patients that are having heart attacks have a calcium score of 0, so it's missing those patients. And the calcium score is probably more of a biomarker than the actual plaque that's rupturing. And calcium scoring may not work that well in the younger patients because younger patients don't have calcified plaque. It's really the older patients, over 60 years old. So, 30, 40, 50-year-old patients, where you're trying to really promote prevention in an earlier way, I don't think it's going to be the best approach because only a third of those patients have calcium scoring. And so I think there's a role. I think it's a high value proposition, but I think it's still missing a lot of patients that have disease, and that's the lessons from Miami Heart and SCAPUS. Yeah. 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 Right. So, all right. So it's three preventative questions that are underlying there. One's about prognostic value of a negative stress test or especially negative exercise treadmill test. So, negative stress test means that you're unlikely to have an event at 1 year. And the chest pain guidelines author put a warranty period of 1 year on the stress test. So I think that's true. And would he have died? Right? Maybe not. And so I think maybe mortality is not the only endpoint to look at, and the value of exercise stress testing, I think, as much as in the exercise capacity and the hemodynamics that you get out of that, as much as it is the risk prediction. What was the second one? Was cool. Yeah. Yeah, so pool cohort equations. So part of why calcium scoring gets into the prevention guidelines is that the pool cohort equations, even though they are multi-ethnic and multiple studies that go into it, they still overestimate risk significantly, and it means that you're going to overtreat. People have said, if there's 60 million patients that should be treated with statin therapy based on pool cohort equations, there may be at least 10 to 15 million patients that are being unnecessarily treated. And so pool cohort equations, and they don't work as well also in younger patient populations, right? So then you have to think about lifetime risk score, but lifetime risk score has no validation behind it. So I think that's when we looked, we did this just in our local population and trying to do, trying to just see, answer that question. 60% of the patients that had an ASCVD risk under 7.5%. Had demonstrable atherosclerosis and plaque, and maybe they should be treated. And so to us, that was a big number of patients that we were missing also. So it goes both ways, overestimation and underestimation of risk. Yeah. So I think of the CERT trial, CIRT. I don't know if you guys participated in the CERT trial. We were part of it too, and it didn't go so well, right? It stopped early because of there is certainly inflammation, and my colleagues that are in this space, and Paul Ricker is a genius, right? I think have pointed, there is inflammation, but is it specific enough to be able to answer questions? And yeah, I mean, some of the even a drug like methotrexate, or even the novel anti-inflammatory agents, the absolute risk reduction of it's pretty expensive, to identify a patient just based on inflammation alone, that for a drug therapy, and it's the inflammatory marker is very non-specific. I think there's a value in, if, right, this is we're talking about the next 10 years, right? And so if you're thinking about what's the simplest thing I can do at my clinic today for a 45-year-old where I'm trying to risk stratify them, I think it's reasonable to do a CRP, because you have to do what you have available to you and what you have access to. So, all right, let me wrap up this, because I know we're past time here. I just wanted to answer this question around CT and CTFFR. And so CTFFR allows us to combine coronary anatomy and flow through computational fluid dynamics. I was thinking about it a decade ago, and many others have been thinking it much more deeply. And so can we predict what's happening at the distal coronary? This is data just published in JACC Imaging a couple of weeks ago. 12 centers from the United Kingdom, Mittal, McCallion, Ed Nicol, who's will be president of SECT soon. Looking at those patients that were referred for CTFFR, some of the accuracy data depends on the rejection rate. 40% of the patients had moderate stenosis, but the positive predictive value was only 49%. And the cost of CTFFR was 40% higher than SPECT and 24% higher than stress CMR. And this is in the UK and NHS. And so, I've been very enthusiastic. It's in the guidelines. There is a ton of pros to CTFFR. You can avoid layered testing. There's excellent prognosis with a negative CTFFR in a trial environment. And maybe more as a continuous variable, so not using 0.8 as a cutoff, but maybe 0.75 to 0.8 gives you the continuum of risk. And it's a 2A in the guidelines for 40 to 90% stenosis. But there are important questions. And what are the outcomes impact in the real world? What's the accuracy in the real world? There is high cost to this. And maybe it's only applied for about 10% of cases. And so this will be out in JACC Imaging in a couple of weeks. And where I think CTFFR will fall is, how do we think about just CAD imaging now? Well, maybe we leverage the class 1A evidence in CTA for intermediate risk stable chest pain. We focus on image quality. We exclude high risk anatomy, and that there's a new CAD image triple aim. So we can do stenosis, plaque quantification, and we refine our ischemia testing, and not to forget about the microvasculature. And so where the field is going, functioning significant plaque, and so how we use AI to be able to determine ischemia or function significant CAD. This is from Korea. And something that we presented at ACC, doing a model feature extraction and model prediction using based on the CT imaging, 37 parts of this algorithm to predict ischemia or no ischemia. We did internal, external validation with credence and Pacific. Pacific trial data was presented at ACC. The credence part of this is going to be a late breaker at EACVI in a couple of weeks from Alex Van Roosendaal, but showing that this AI QCT ischemia tool, so using a CT, using 37 plaque parameters, of which stenosis and plaque diffuseness were among, stenosis is still the most important factor, but also plaque diffuseness was just as accurate as PET imaging, as is water PET, and FFRCT, and at least in this cohort, in predicting ischemia. And this is what it looks like in its clinical form, but point out not FDA approved yet. Other approaches, non-invasive FFR estimation using histologically validated quantitative plaque assessment, also showing high accuracy, and this is courtesy of Todd Malines. And so I think this is where the field is going. And so just on a clinical basis, what should we do? Do CT first, we get stenosis, plaque burden, and quantitation. Make sure we get our patients in goal-directed medical therapy, and then maybe you apply any of these ischemia assessment tools for about 10 to 15% per guidelines. by ACC guidelines for those patients with 40 to 90% stenosis, and by CAD-RADS 2.0, which is an SECT multi-society document of 50 to 90%. And image quality is key. And there are new approaches that will help us determine functional approaches to CAD. And so last point, Dr. Sengupta, this PRIME checklist that underlies every paper that goes to JACC Imaging. If you want to do something new in AI and imaging, it has to pass this PRIME checklist test for data standardization, model assessment, and replicability. AI and CT is very much part of prevention, but we do have to validate this. Some of the future studies include the WISDOM trial and Confirm 2, which will look at a large registry, about 40 sites right now that are participating with long-term follow-up, subgroup analysis, and this Transform trial that will answer the question Dr. Sengupta asked. What's the plaque regression that you're going to see with treatment, and looking at different groups of patients with long-term outcomes, so that maybe this is what will be part of the next 10 years of care and also the next guidelines. And then I think something from ACC 2023 I thought was very interesting is around virtual clinical trials and how we use AI to do the virtual trial itself. And again, Partho is the expert in this area, so that by doing this, how do we make our lives easier? How do we act as a second reader? How do we reduce the time spent on comprehensive assessment? And how do we translate the decades of evidence that we have available and improve our adherence to guidelines? And so AI-guided CTA will prevent heart attacks through enhanced identification of atherosclerosis, and I think the future is here. And so thank you for your time and attention.
Thank you very much. So, thank you very much. That was a very eloquent lecture. I was sitting with Andrew and discussing it. What happens there? And I was hearing that perhaps of the whole we all know about the black hole phenomenon, and answer the question volume does builds out without really approaching into the human, changing the blood flow rheology inside health. But imaging is going to be key, and applying the right sets of tool and having an understanding through. So it's not also about the AI. I find the fun part is the rediscovering the whole physiology and understanding about cardiology. And many of the clinical trials are just based upon those assumptions. And those assumptions may not be valid. So that is very exciting, and really want to thank you, Andrew, for the work that you, for the entire crowd here for coming up. And I want to really also acknowledge some of our colleagues from internet, because it's going to be a very nice, engaging between one bridge of prevention to how you intervene, and when you intervene. It's going to be, the future is going to be very exciting, and it's going to be complex than we think it is. As we go into the complex environment, using perhaps will play some roles. Thank you, everyone.
All right, well said.
Here's a question.